I want to welcome everybody to this discussion on the role of biosimilars, obviously a very relevant topic to drug development and clinical practice. And we have two speakers that are going to provide us insights into this area. The first is Andy Zelenitz from Memorial Sloan Kettering, who also serves as the chair of the NCCN Non-Hodgkin's Lymphoma panel. And Andy's going to provide us sort of a broad overview, our understanding of what the issues are related to biosimilars. And then to get rather granular, because there is a single drug that is approved, Pamela Becker from the University of Washington, who serves as the vice chair of the myeloid growth factor panel, will really give us some insight into that drug and the many others that are actually potentially going to be available to us in the near term. So with that, we're going to start, and I'd ask Andy to come up.
Well, thank you for that introduction. NCCN actually has been involved and thinking about biosimilars for a number of years. A number of years ago, we had a task force that produced a white paper which had a bunch of suggestions for guidelines and development of biosimilars that are largely seen in the FDA guidelines. So we did actually have some influence, I think. We have a couple of questions. We're going to ask them now, and we're going to ask them after. I'm not going to discuss them now. We're only going to discuss them after. The first question is here. A 66-year-old former firefighter presents with severe back pain, found to have a L1 compression fracture associated with a paraspinous mass and a spinal cord compression. The biopsy demonstrates a plasmacytoma and a 414 translocation by FISH. Additional evaluation reveals a monoclonal gammopathy, IgG kappa, 7.3 grams, kappa light chains of 1,740, and a creatinine of 3.4. He undergoes radiation for the paraspinous mass. Is treated with 4 cycles of bortezomib, cyclophosphamide, dexamethasone with a decline in the M spike to 1.4 gram per deciliter. The kappa-free light chain drops to 221. He arrives for autotransplant, and the decision is made to treat him with a cycle of VRD PACE to get further cytoreduction. Which growth factor should he receive after completion of the chemotherapy drugs? Filgrastim, tibofilgrastim, filgrastim SNDZ, or any of the above? Okay, that was too fast. Okay, so next question. If the regimen were being used for mobilization of peripheral blood progenitor cells and you're restricted to an FDA-approved indication, which could be used? Filgrastim or tibofilgrastim, filgrastim or filgrastim SNDZ, tibofilgrastim or filgrastim SNDZ, or just filgrastim? Okay, so we have some opportunities for education. Tibofilgrastim was an FDA-approved, yes, most people got it wrong, don't worry. Tibofilgrastim was FDA-approved through the application process as a generic, a biosimilar, a biologic as a new drug, or an interchangeable biological product. Okay, excellent. So we are ready to go on. We can make the slide go away. There we go. Okay. I'm going to review the impact of biologics in oncology. I'm going to talk about biosimilars in general and talk something about the difference between biosimilars and the reference biologicals. Hopefully at the end of this, it will set you up to understand what a real biosimilar is and how it's used clinically. Biologics have become the cornerstone of many areas of modern medicine, but they are critically important in the management of cancer, both as supportive agents to treat cytopenias, as well as active therapeutic agents such as rituximab, trastuzumab, and the list goes on. Unfortunately, biologics are very expensive, and as a result, the therapeutic spending in oncology dominates all of medicine spending, accounting for $28 billion at the time of this survey in 2014. And if we look at the 10 most used drugs, and this is 2012 data, we can see that the biologics shown in red are the dominant drugs, and many of them are drugs used for management of cancer patients. But the biologic era is now quite mature, and a number of drugs are moving from a patent status to a patent expiration. The patent laws are different in the US and Europe, so patent expirations are different. A number of agents have been available as off patent in Europe for some time, and including the growth factors. But in the United States, there are a number of agents whose patent lives are expiring in the very near term. So about 50% of the biological market is in oncology, so clearly understanding how we could substitute a biosimilar biologic in oncology is critically important. As I already mentioned, these are critical in supportive care as well as active therapy. Cancer therapy costs have outstripped the costs of the growth in healthcare in general, and of course the growth in healthcare in general has outstripped the growth in the US GDP. In part, it's because drug pricing has become somewhat what I would call irrational. Drug prices are now based on what the guy got last time, not really what the inherent necessarily value of a drug is. So there has been a stepwise increase in the cost of cancer care rather than what I would consider rational drug dosing pricing. So what about small molecules? Well, small molecules are generally very well chemically defined. Most of the time are very easy to make in chemical synthesis. Of course, there are some exceptions. We know that paclitaxel was a very difficult chemical synthesis. It can be done, but it was a difficult chemical synthesis. But in general, these are very well defined, very easy, reproducible, and you can absolutely be unequivocal about the structure of a molecule when you're done with your chemical synthesis. Biologics are different. They typically are made in living systems, either bacteria or mammalian cells. These, as a result, often have post-translational modifications. An example is shown here is trastuzumab, which is used in breast cancer. And here's a molecule of 185,000 kilodaltons, compared to 558 daltons for atorvastatin. Here's just another picture. I love this picture, so I'm showing it. But here's aspirin, and here on the same scale with the same modeling is a monoclonal antibody. Obviously, making the aspirin is a lot easier. I actually made aspirin for a project in high school, in a high school laboratory. I did not make a monoclonal antibody in a high school laboratory. So why is it so difficult? Well, so let's think about manufacture of a biologic. We start with a gene that's cloned. and that we can pretty much agree is going to be the same gene. That's where the similarity between the originator and the biosimilar end. Because it's not necessarily true that the gene that you're going to express is going to be in the same expression vector. And it's certainly true it's not going to be in the same cells, because the originator is unlikely to make the cell bank available to a competitor to make exactly the same molecule. So we're going to have variations in cells, we're going to have variations in conditions, we're going to have variations in scale. And all of these have the potential to introduce important biological variants through the course of the manufacture of a biologic. This has been well recognized for many years. There is an international standard that regulates the variation of manufacturing processes. If Genentech wants to make rituximab on another scale with another process, they can't just make rituximab. They actually have to submit to the FDA and the EMA using these ICH Q5E guidelines and prove that the process changes introduced a minimal change that has no significant impact. And the agencies can request and require clinical trial validation of the equivalence of molecules that undergo a process change. This is ongoing for a long time. Why? Because originator molecules vary. Do they really? Yes, they really do. Here's an example of darbepoetin. These are multiple lots, and you can see here, these are multiple lots obtained before a process change. Here are 2 lots obtained after a process change, and they have a different isoform composition. This was felt to be not clinically relevant, and the molecule was allowed to continue despite this process change. Here's another example of rituximab, and you can see that, again, after a process change, there were some pretty significant differences. For instance, we see differences in basic variants, very clearly seen here in this middle panel. But importantly, we also see very big differences in ADCC. There's about a 20% increase in ADCC after the process change. The major mechanism of action of rituximab is antibody-dependent cell-mediated cytotoxicity. So is this really a small difference that is meaningless? Well, I can tell you that this wouldn't meet FDA guidelines for a biosimilar. This is too much of a difference to be a biosimilar. The same occurred in non-oncologic drugs such as etanercept. And then we always have the concern that when you're making a molecule in a new system with potentially slightly different post-translational modifications, that you're going to have new risk for immunogenicity. Changes in the structure increases the risk for immunogenicity. And immunogenicity is a major risk for loss of clinical efficacy. And it also raises questions about interchangeability going from a biosimilar to the originator. So we know that change in formulation of an originator can have a big impact. So one process change that occurred in the development of erythropoietin was the substitution of polysorbate 80 for human serum albumin in the production process. And unbeknownst to the manufacturer, this was actually interacting with the packaging and resulted in a significant rise of the risk of pure red cell aplasia. Pure red cell aplasia associated with erythropoietins was essentially a non-entity, and all of a sudden became almost epidemic. And it turned out it was because the polysorbate was interacting with the rubber cap, and once you coated the rubber cap, this toxicity went away. So these process changes are really important, and it's really important to understand the consequence of them. So what about biosimilars versus the reference product? So both the FDA and the EMA have defined biosimilars. I'm going to focus on the EMA definition because it's more understandable and I like it better. So it's a structurally highly similar version of an already authorized biological medicinal product, the reference product, with demonstrated similarity in physiochemical structure, efficacy, and safety based on a comprehensive comparability exercise. The FDA definition is exactly the same, but it's more difficult to read. So the problem here is what I alluded to earlier, that it's difficult to manufacture an absolutely identical copy. There's no such thing as a generic biological molecule. We can't, even I just showed you that the reference product is not an identical product of itself over time. How could another manufactured product be identical? And so the question is, can you make them sufficiently similar so that the differences are not clinically relevant? We have different paths. First of all, you're the first to market. It doesn't matter what the competitor has done. You actually are defining a new agent in the field. You have to provide standard data package, and you don't have to compare to a reference. If you want to follow what's now called the 351K pathway, that is the biosimilar, the molecule has to undergo a pretty comprehensive set of preclinical evaluation to show that it is really quite identical to the reference product and not meaningfully different. Then once you get to the clinic, you can give a much more abbreviated package of clinical data. And we have an example with filgrastim SNDZ. An interchangeable biosimilar is one that would permit drug substitution according to state pharmacy laws if the state pharmacy laws said you could substitute without notifying the physician. There are no interchangeable biosimilars in the United States. And then we could have a full BLA, a biological license application that's a copy, but it has to go through a standard data package, and we actually have an example of that with tibofilgrastim. So what are some of the competing interests here? Well, if you have biosimilars, are we going to, impact our ability to compete and innovate? And I actually think just the opposite. I think that as we can bring down the costs of some of the drugs we've been using for 15 or 20 years, the reality is there's now room in the market to pay for new innovation. And one of the big advantages here is the cost of development of a biosimilar is made much less expensive because you don't have to prove efficacy in every single clinical indication. It only needs to be proven in the quote-unquote most sensitive clinical indication. So it all starts with the preclinical assessment, and the more you do preclinically, the less has to be done clinically. If two molecules, when you do the isoelectric focusing and the sequencing, this and that and the other thing, don't look very similar, there's no development on the biosimilar pathway. If a drug is only deemed similar, then there actually will be much more requirements for clinical validation. But when molecules become highly similar or have near fingerprint identity from the preclinical evaluation, then very limited clinical data is actually necessary to prove safety. So structure and function is the foundation of the preclinical assessment. Obviously, the first thing that happens is you prove that the amino acid sequence is the same, that the higher order structures are the same, that the glycosylation pattern is similar, it will not be the same, and that the pegylation is similar in appropriate molecules. You also clinically have to evaluate your ability to produce the molecule with minimal lot-to-lot variation. Then it's important that some preclinical in vitro activity be evaluated, particularly if there are clear PD markers that one could use, and biological assays for the molecule. So here are some of the things that one looks for to prove near fingerprint identity: primary sequence, peptide mapping, higher order structures, glycoforms, and impurities. Then we have to prove that the molecule transduces signals the same way, that it binds to the receptor in the same way, that it elicits effector function in the same way, and has similar cytotoxicity. This is, there's going to be a quiz, so I want everyone to take notes on this. We're going to quiz on this one. No, this is actually shock and awe. This is, believe it or not, a partial list of the analytics that were done for GP 2013, a putative biosimilar for rituximab. This is not the exhaustive list of the preclinical characterization. If we look at the molecule, rituximab versus GP 2013, we can see that the molecule is really remarkably similar to rituximab. So if we focus here, we can see the lysine digests are similar, the NMR is identical, but I want to point out one thing that's interesting, is that this molecule was compared to pre- and post-process changes of the originator. And it was actually only biosimilar to one of the two molecules, because the two molecules were not biosimilar to each other. The reference product was not biosimilar with itself. Okay? So there was drift in the reference product. So but three-dimensional structure was the same, and in fact, there was a tighter reproducibility in ADCC and complement-mediated fixation and induction of apoptosis than in the reference product on multiple lots. So once you've established the preclinical, okay, now it's time to move to the clinic. So what do you need? Well, here, the foundation is, sorry, I already touched on this. Here the foundation is pharmacokinetics. Okay, once you have a molecule, you think it's the same, it has near fingerprint identity, you bring it into the clinic and you do a PK study. The PK study has to fall within the same range of the PK analysis of the originator, so you have to compare it to the originator. And if this is passed, then you go on to a clinical trial. And the clinical trial requires the identification of similarity in PK, PD, and then testing in what is considered clinically the most sensitive indication that is clearly open to debate and discussion. How much needs to be done in the clinic really will depend on how close they are up to this point. So the FDA says if you have near fingerprint identity, the PK/PD is similar, you have to do almost nothing in terms of clinical activity. If they're biosimilar but not near fingerprint identity, a larger clinical trial with a non-inferiority design needs to be performed. But biosimilars do not need to prove outcomes, because the proof of the outcome has already been done by the originator molecule. You just need to show that it is not different than the originator molecule. So in conclusion, biologics are the cornerstone for the treatment of clinical oncology today. These are complex drugs. They cannot be made generic. They are inherently different. A biosimilar and its originator are inherently different drugs, but the differences need to be not clinically meaningful. That's the only way it's actually truly a biosimilar. The biosimilarity is measured on preclinical analytic exercise as well as clinical evaluation. The design of the comparability trials is based on non-inferiority, not on superiority, and not improving clinical efficacy that goes beyond the reference product. So from a clinician's point of view, Some clinicians are skeptical because they're unfamiliar with new therapies. They really want data in efficacy, safety, and reimbursement. I believe that clinicians will want more, at least early in the days of biosimilars, will want more clinical validation than less. There's a lot of concern, and we know this from an NCCN surveys that we took, that physicians are concerned that these biosimilars are going to be forced on them and they won't have a choice, and that everything is going to be cost. And I think education is critically important, which is why I'm standing here today. From the industry perspective, biosimilar development is still complex. Changing the conditions so that you get a truly biosimilar molecule is not an easy exercise, but it's still much less expensive than producing a novel biologic. So unlike generics where it could be cents on the dollar, biosimilars will have a 20 to 40% estimated decrease in price compared to the reference biologics. But this is even enough to provide some cost competition. There are biosimilars that are under review and some that have been approved. So what about the implications for the NCCN? So a biosimilar represents a functional equivalent molecule to the originator product. So when a biosimilar is available, it should be added as an alternative to the originator. And I'll give you an example in the NCCN NHL guidelines. R-CHOP is the standard of therapy for diffuse large B-cell lymphoma. Biosimilar rituximab plus CHOP will be added when there's a biosimilar. Why? Because it's a biosimilar. It has already shown that it gets all the indications that rituximab. But it would not be appropriate to say anti-CD20 plus CHOP. Why? Because there are other anti-CD20s, ofatumumab and obinutuzumab, that are not biosimilar to rituximab, and it's critically important. So with that overall introduction, I'd like Dr. Becker to come, and she's going to focus this on a real-world example with the growth factors.
Good afternoon. So my title, my part of this will be that the NCCN guidelines meet the biosimilar myeloid growth factors. So the growth factors are important for myeloid proliferation and differentiation. The one I'll be focusing on today is granulocyte colony stimulating factor, which acts on a primitive pluripotent stem cell as well as during myeloid maturation to the neutrophil. There are a number of FDA-approved recombinant growth factors and growth factor mimetics. So there are the erythroid factors, erythropoietin, darbepoetin, the myeloid growth factors, filgrastim, pegfilgrastim, also sargramostim, and others. Romiplastim and ultromepeg are growth factor mimetics. So what's new on the horizon now is that there are now similar and biosimilar growth factors. And there's one biosimilar growth factor that's now been FDA approved, and I'll be reviewing the details. So you've just heard from Dr. Zelenitz a very long discussion of what are biosimilars, and biosimilars depends on your viewpoint. Biosimilar biologics, never identical but close enough. So the FDA would probably say it has to be really close. The legal pathway to development of biosimilars was based on two different acts, the Biologics Price Competition and Innovation Act of 2009 and the Patient Protection and Affordable Care Act of 2010. These were part of a new healthcare system with the goal that there would be reduction in the cost of healthcare. So the cost was a driver in this development. So as you just heard, the FDA approval process can either involve a biologics license application, which is the conventional historic way that all the biologics have been approved, where safety and efficacy both need to be demonstrated, or the biosimilar, this is the new pathway, the biosimilars pathway, a biosimilar biologics license application. And as you just heard, first has to be demonstrated that they're highly similar, but then there's this other entity, interchangeable biosimilar, and more data is needed for that. So the biosimilars are approved because they're highly similar to the reference product with no clinically meaningful differences, but the interchangeable biologic product has to meet that biosimilarity standard and produce the same clinical result. And we, at present time, do not have an interchangeable biological product. If you go to the FDA website, you find this little interesting video show. They're saying that biosimilars, making more treatment options available to more people. So this is their advertisement. This is what they view as advantage of the biosimilars. Filgrastim was first cloned in 1986, and the recombinant form was manufactured in E. coli bacteria. It is not glycosylated, although the natural granulocyte kinase stimulating factor is glycosylated. It has identical biologic activity as the natural growth factor, and this reference is from 1986. The FDA approved filgrastim in 1991, and the patent expired first in Europe in 2006, and then the US in 2013. Because of this much earlier time frame of the patent expiration, the European approvals of biosimilars has been in advance of the US. The indications for filgrastim are for patients with non-myeloid malignancies receiving myelosuppressive chemotherapy associated with a significant incidence of febrile neutropenia. Also indications in blood and marrow transplantation, peripheral blood progenitor cell collection, severe chronic neutropenia, patients with AML receiving induction or consolidation chemotherapy, and patients with HIV infection. Pegfilgrastim, it's a pegylated form, and this was also FDA approved for the same first indication for patients receiving myelosuppressive chemotherapy. And there's a new indication, which is to increase survival in patients acutely exposed to myelosuppressive doses of radiation or acute radiation syndrome. The side effects, bone pain, allergic reactions, acute respiratory distress syndrome, alveolar hemorrhage, splenic rupture, fatal sickle cell crises, Sweet syndrome, cutaneous vasculitis. There's been a theoretical concern for some time that there could be an incidence of MDS or AML, and there has been an increased hazard ratio, but the absolute risk is very low. So this is a partial list of the current products, G-CSF products. Filgrastim, which was the reference product, is non-glycosylated. Tibofilgrastim is also made in E. coli, also non-glycosylated. It was approved in Europe as a biosimilar in 2008, so it did meet all the requirements to be a biosimilar in Europe and was approved there as a biosimilar. But in the United States, it was FDA approved as its own biologic license application. So it was approved not as a biosimilar. It was approved in the old fashion. Filgrastim SNDZ is also made in E. coli, non-glycosylated. It's identical to filgrastim, except the buffer composition is glutamate rather than acetate. It was also approved as a biosimilar in Europe back in 2008. And then I'll explain more about its approval here as filgrastim SNDZ as a biosimilar. Lenagrastim is a glycosylated form. It's produced in Chinese hamster ovary cells. So the difference is that it's produced in mammalian cells and then it ends up getting appropriately glycosylated. It has been approved overseas, not in the US. The EMA has also approved in 2008 and 2010 two other biosimilar filgrastims, and they're going by the simple name as filgrastim. It's not, there are no other generic names for those, only name brand differences. So what's in a name? Tibofilgrastim was given a prefix of TBO, and if you look through what the FDA has commented on as to how that name came about, there's a small writing at the bottom indicating that the proprietary name review by the DHHS memorandum in 2012 said that TBO stands for toluidine blue O. It was approved in August 2012, not as a biosimilar, but as a biologic, so it has a narrower indication. In addition, if you want to try to compare the two formulations, they aren't described on the package insert in the same fashion. The tibofilgrastim gives the composition as glacial acetic acid, which then is sodium hydroxide used to achieve pH of 4.2. Filgrastim is in a sodium acetate buffer to pH 4.0. In addition, there's a very slight difference in the composition of the polysorbate 80. The studies used to support the approval of tibofilgrastim, initially there were 2 PK and PD studies in healthy controls, and then there were pooled clinical data from 3 different trials where the tibofilgrastim was compared to either placebo or filgrastim. The first study was in breast cancer patients, 348 patients. Patients received a placebo for the first cycle and then were randomized 2 to 2 to 1, tibofilgrastim to filgrastim to placebo. There was a reduction in the days of severe neutropenia from 3.8 days to 1.1 days with a highly significant p-value and no difference in efficacy. The lung cancer study was comprised of 237 patients. Tibofilgrastim was also given during the first cycle, and then there was a randomization of Tibo versus filgrastim for remaining cycles. And again, there was no difference in efficacy. And the last study was in non-Hodgkin's lymphoma patients, 9 patients, randomized 2 to 1, tibofilgrastim versus filgrastim, and there was no difference in efficacy. The most common drug-related adverse events were bone pain, myalgia, and asthenia. Tibofilgrastim was approved with only the following indication: reduction in the duration of severe neutropenia in patients with non-myeloid malignancies receiving myelosuppressive anti-cancer drugs associated with a significant incidence of febrile neutropenia. It was approved with this recommended dose, and it was, as with the other growth factors, the first dose should be at least 24 hours following the myelosuppressive chemotherapy. However, the EMA approved tibofilgrastim as a biosimilar, so it shared all the indications of filgrastim. Not only the chemotherapy-induced neutropenia, but also mobilization of stem cells in autologous and allogeneic settings, use in agranulocytosis, and neutropenia due to infection with HIV. More recently, December 23, 2014, tibofilgrastim for injection by self-administration was also approved. So let's move to the New York Times headline. On March 6, 2015, the FDA approves something, its first biosimilar drug. New York Times didn't realize that it wasn't allowed to use brand names in the title of articles, as we are required here at NCCN guidelines. It was approved as a biosimilar, and it was interchangeable for all indications with filgrastim. This was 5 years from the BPCI Act. So as you heard earlier, Dr. Zelenis explained the physical comparisons that had to be made, and this was done for the biosimilar filgrastim. These are the NMR spectra. The SDS page in non-reducing conditions and in reducing conditions showed identical bands. Circular dichroism spectra showed identical secondary structure, and this two-dimensional NMR fingerprint showed, it turns out that every spot was represented in both the filgrastim and the biosimilar filgrastim. Amino acid sequence, target binding, potency, higher order structure, and high molecular weight aggregates were all analyzed, and this was all submitted to the ODAC at the FDA. The physical chemical characterization was performed, the functional characterization was then performed, and then followed by clinical studies. For the bioactivity, the biosimilar versus the United States reference product, comparator in Europe, all showed equivalency, and there was one PK/PD study performed comparing the biosimilar to the reference product in the United States, and 4 PK/PD studies and 5 non-clinical studies in Europe. For a given dose, 1, 5, or 10 microgram per kilogram subcutaneous of the biosimilar product in the red lines, or the reference product in the green or blue lines, you can see that the absolute neutrophil count rose, and all of these curves were superimposable. And lastly, there was a clinical study comparing the biosimilar filgrastim to filgrastim, and it was complicated in that patients received 6 cycles of just biosimilar versus filgrastim alone versus alternating cycles, where alternating cycles were either filgrastim or biosimilar in reverse orders. And the absolute neutrophil count cycles were seen here, superimposable, until neutrophil recovery at day 10, and later than that, fewer points were obtained, fewer blood counts were needed, and so there's more disparate results, but this was all considered identical. What about the promise of reduced cost? The studies performed in Europe to date show that if a biosimilar versus filgrastim versus pegfilgrastim are compared, that the biosimilar seen in the white bars was uniformly less expensive when used for indications of non-Hodgkin's lymphoma, breast cancer, or lung cancer compared to filgrastim, but the far lower in cost than pegfilgrastim for any of those indications. So I thought, I wonder what's going on in my area. So I looked up on the internet and looked at the Seattle pharmacies. These are the non-academic pharmacies, non-hospital pharmacies, commercial pharmacies in the area, and just looked up and thought, what's the difference? So I looked up filgrastim, and I found 6 fairly close costs. And then I looked up tibofilgrastim, and the costs were higher. And I thought, how did that happen? And so then I put in filgrastim SNDZ, and I got exactly the same numbers as I did for filgrastim. So filgrastim, which I assume is probably the filgrastim SNDZ, is showing to be lower in cost than tibofilgrastim for 6 pharmacies in Seattle. So the Myeloid Growth Factor Committee has serially considered, first we had to consider tibofilgrastim and what to do about the guidelines for tibo, and then most recently this year we had to also consider what to do for the filgrastim SNDZ. How would we deal with this? So let me show you what we came up with. So first, we had to give some definitions. So we first defined that GCSF could be defined here in the red box, that GCSF refers to the following approved agents: filgrastim, filgrastim SNDZ, tibofilgrastim, and pegfilgrastim. So we used the term GCSF on some of our pages. This first page is evaluation prior to first chemotherapy cycle, and we just are using the general term GCSF. The next page is assessing patient risk factors for febrile neutropenia. And here, again, we used just GCSF and said that it could be one of these 4 agents. For our third page, again, this one was evaluation prior to second and subsequent chemotherapy cycles. We just used GCSF. When it came to therapy during febrile neutropenia, so when patients present with febrile neutropenia and they're already on prophylactic filgrastim or filgrastim SNDZ or tibofilgrastim, whatever agent they're on, we recommend it to be continued. For patients who receive prophylactic pegfilgrastim, no additional growth factor should be needed. And for patients who did not receive prophylactic GCSF and risk factors were not present for an infection-associated complication, no therapeutic growth factors. If the patients are at greater risk, then one of the growth factors could be considered. For the prophylaxis of febrile neutropenia and maintenance of scheduled dose delivery, there's category 1 evidence for filgrastim, for tibofilgrastim, and for filgrastim SNDZ. And as you've heard, all of those are FDA approved. Those are all FDA approved indications. So then we realized that we had great difficulty with tibofilgrastim, where this was not FDA approved in the autologous transplant setting. It was not approved for mobilization, and it was not approved post-transplant. So there are a couple studies that have been performed where there was direct comparison. The other reason why this became so important is that over the last couple of years, the NCCN member institutions, we were relating to each other that our pharmacies were changing over, or insurance companies were changing over and saying that they were only going to approve tibofilgrastim. Tibofilgrastim was FDA approved first. So we have these 2 studies to reference in the autologous transplant setting. The first one was comprised of 185 patients. 86 received filgrastim, 99 tibofilgrastim. There was no difference in the primary outcome of the median number of CD34 cells collected. There was no difference in engraftment, and tibofilgrastim was associated with decreased cost. The second study was 182 patients, where 91 of them were before the formulary change of that institution to tibofilgrastim. So the 91 patients, so they weren't randomized, it was just sequential, and they found no difference in the CD34 positive cell dose obtained, and no difference in time to neutrophil recovery. And I call your attention to the title, the subtitle of this second article, Thibault or not Thibault? That is the question. We then considered as a group, so we know that we're not on FDA approved, we don't have an FDA approved indication, and yet our guideline is going to say that it's okay to do that, and this is the basis on that decision was made by consensus of the member institutions. A vote was taken. And category 2A, that there was uniform NCCN consensus that the intervention was appropriate, or category 2B, that there was NCCN lower level of evidence that there was the intervention was appropriate. So it depended on the percent of institutions. So the majority gave us category 2B. The mobilization of hematopoietic progenitor cells in the autologous setting, category 2A, following combination chemotherapy before autologous transplant with the goal of mobilization during count recovery, category 2A. In combination with plerixafor for mobilization of hematopoietic progenitor cells in the autologous setting was category 2A. We had more difficulty and more debate when it came to mobilization of allogeneic donors. I'll show you in a couple minutes a couple publications where there were publications that requested that caution be used both in the related and unrelated donor setting to use these new growth factors for mobilizing normal donors where there wasn't as much information. So we had category 2B support for mobilization of allogeneic donors and also for granulocyte transfusion in the allogeneic setting. What about cost effectiveness in the autologous transplant setting? This was the filgrastim versus biosimilar filgrastim in Europe. So in this study referenced below, there was no difference in the number of GCSF injections. There was no difference in the duration of hospitalization, no difference in the days of neutropenia, no difference in the other blood counts or the number of red cell or platelet transfusions or the days of total parenteral nutrition. The cost comparison was actually highly significant. This is in euros, but compared to the overall cost of transplant, there was no significant difference. So even for these days of the growth factor that were used, it didn't impact the cost of autologous transplant in this one European study. So this is a little more complicated. This is our MGFD page, the use of myeloid growth factors in mobilization and after hematopoietic cell transplant. So we have suggested that filgrastim or filgrastim SNDZ or tebofilgrastim can all be used for mobilization, that if combination chemotherapy is used, that all three agents can be used with the goal of mobilization after the chemotherapy, that if a combination of growth factors is used, that filgrastim or filgrastim SNDZ, the biosimilars, can be used in combination with GM-CSF for mobilization, that the combination of plerixafor, that any of the growth factors can be used with plerixafor for the selected patients who have had heavy pretreatment or who exhibit poor mobilization, could be added just in time or rescue, that any of the growth factors could be permitted in that setting. And the dosing that we have provided is identical. And in terms of studies that have been done for normal allogeneic donors, these three studies have been performed. 22 donors, half were given tebofilgrastim, half filgrastim, and there were no significant differences in the CD34 count after mobilization, the number of leukapheresis procedures, the number of CD3 positive T lymphocytes, or regeneration of blood counts after transplant. In a second study of 36 donors that were randomized, biosimilar filgrastim versus filgrastim, it was found to be safe. There was only a slight difference in the CD34 positive cell numbers, but all collections were over the minimal target. And lastly, in a study of 24 sibling donors, tebofilgrastim was compared to historical controls, no difference in CD34 positive cell counts, time to engraftment, or side effects. These are the two papers listed below, the potential for ethical concern about using a biosimilar growth factor for mobilization in normal donors, or the World Marrow Donor Association cautioning that there are potential concerns to use biosimilar colony-stimulating growth factors for mobilization. Note that the date of these are 2011 and 2012, so now approaching 5 years ago, and we believe that it, as we now show in the current guidelines, that we have Category 2B for filgrastim or filgrastim SNDZ, the biosimilars, and Category 2B for tebofilgrastim in allogeneic donors, and that for supportive care, filgrastim or the other two, the filgrastim SNDZ or tebofilgrastim, can be used for supportive care. In summary, the tebofilgrastim was FDA approved by the conventional biologics license application to reduce duration of severe neutropenia with myelosuppressive chemotherapy. Filgrastim SNDZ was approved as a true biosimilar by the biosimilars pathway for all the same indications as filgrastim. And we're all now presented with a practical issue in that our hospital formularies are interchanging growth factors, and then there are also insurer mandates that are only permitting use of certain growth factors, and so it's making it more difficult for us to intellectually or academically decide what we think ought to happen or what we have clinical trial data for versus what we're presented as practical matter. So I think we're back to our audience response system. So we have the same case as before, the 66-year-old former firefighter who presented with new diagnosis of multiple myeloma and now needs to receive this myelosuppressive, highly myelosuppressive VRD-PACE chemotherapy regimen, and which growth factors should he receive after the completion of the chemotherapy drugs. I can't mimic the music as well as Dr. Salins. So we've got the comparison charts showing that there's been a big increase in that any of these growth factors, and we agree that any of these growth factors would be able to be used in that situation. We've got the filgrastim and the filgrastim SNDZ, which are biosimilars, and they're all approved for the indication, and then tebofilgrastim was independently FDA approved for the indication to be used for myelosuppressive chemotherapy. Next slide. Thank you. If this regimen was being used for mobilization of peripheral blood stem cells and you were restricted to the FDA-approved indication, which could be used? We have the same 4 choices as last time. So earlier, it was choice 4, just filgrastim, because I think that probably sounds like the most comfortable for everybody, that they know filgrastim could be used. But now there's been a big switch over to filgrastim or filgrastim SNDZ, which is correct, that these, either of these, they were all approved as biosimilars. They're all approved to be able to be used for mobilization of peripheral blood progenitor cells. So we've seen a shift there from 14% to 53%, and we are happy about that. And lastly, tebofilgrastim was FDA approved through the application process as a generic, a biosimilar, a biologic through the traditional biologic license application, or an interchangeable biologic product. So now the third choice is correct. It went through the conventional biologic license application, and it was approved that mechanism, which is, and not as a biosimilar. So no, it did not meet all those criteria that I showed you that the filgrastim SNDZ met. It did not go through that pathway. It underwent conventional clinical trials in comparison to filgrastim, and so choice 3 is correct. So I like to, it's nice to see those changes in the responses.